and gentlemen, warm welcome to this third Sidra Symposium. As you remember, we discussed about obesity and pregnancy and childhood and neonatal screening, and today, in the third Sidra Symposium, we will discuss about preterm labor, prevention, diagnosis and treatment. I'm very happy to welcome you all from different parts of the country and from a lot of colleagues from Hamad and the Women's Hospital and the Supreme Council of Health and the primary healthcare centers, and I'm happy to have you all here and we can discuss one of the main topics of obstetrics, the preterm labor. I wish to remember you that you can get CMA points here. The certificate is outside, and please use it if you wish to be educated the whole life. The preterm labor isn't a problem from Qatar or from Doha. It's a global problem. And therefore, I'm very happy that I can welcome Dr. Michael Katz. He is a famous scientist, and he is a senior advisor in research from the March of Dimes. And in his life before, this very important leading position in this research foundation, which is focused on the problems of preterm labor in the United States and worldwide. In his life before, he got the medical degree in the State University of New York, and after his residencyship in the Babies Hospital in New York, and a lot of other different positions. You can read it in your handouts. He was professor and chairman of the Department of Pediatrics in Columbia in Manhattan. But I wish to mention that he got the Senior Scientist Award from the Alexander von Humboldt Foundation. That's a German foundation, therefore I must point out it. And he was consultant of the WHO and the UNICEF and a lot of global organizations. And one main interest of March of Dimes since several years is the rate and the dangers and the possibilities of treatment of preterm labor. And therefore he is the person, the scientist of the world to speak about global aspects of preterm labor, research, treatment, possibilities. And I'm happy to see you here, and thank you for coming, and that's your floor.
Good afternoon or good evening. I am very grateful for the invitation that has given me the opportunity to come to Qatar. The hospitality with which I have been treated is amazing, and I have nothing but distinct pleasure of having experienced it. It is also extremely nice to be in a country where such progress is patently obvious. It is not sufficient to have economic resources. One needs to have wisdom, and that seems to have laced the process here. In the short time that I've been here, I saw an enormous amount of effort and the type of vision that this country is experiencing is remarkable. So I wish you very well, and I hope to be able to come back someday and to see the progress that has been accomplished. There seems to be some music coming in, but I'm not sure what its objective is. Fine. The problem of prematurity is a global one, and it is my intention to stress 4 points in my presentation. Point number 1 is that it is a very serious public health problem for the entire world and every country. Point number 2 is that it must be acknowledged, recognized, and analyzed, and I will present some information about that. Point number 3 is that especially in countries of higher resource, there is some effort that can help to prevent a proportion of premature labor situations. Number 4 is that until we solve the biological question of what constitutes the basis of premature labor, we will not be able to prevent it effectively. And those will be the steps that I will attempt to show you. So here is a curve from the United States, although it could be from many other countries, showing you the births. All births are increasing in the number of premature babies born through the year 2006 has been rising. I'll come back to this in a few minutes. You will notice also that the major proportion of preterm birth are the late preterm births, and I come back to that point in a moment. Now, if you look at the same set of data in a bar graph, you will see the same kind of rise. You will notice that this rise is primarily due to the late preterm births. But even more important, if you look on the very preterm births, there has been absolutely no change. And this allows us to infer that there must be a basic genetic problem that is responsible for these births, and that is where we should look for the causes. Furthermore, in global causes of child death for the year 2010, the last time WHO has published these data, you will notice that preterm birth is the number 2 cause of infant mortality throughout the world, the first cause being respiratory infections. As a result of this, Marjorie Dimes and several other organizations in WHO decided to see what the rates of preterm birth have been throughout the world. These data are very carefully collected. They're not all absolutely precise because the data are not always accessible, but we now have information about every country in the world, and this report, Born Too Soon, reflects that. As I mentioned to Professor Ludenheim, we have a book that has this information, and if any one of you wants that, please leave your name with the Sidra staff, and we will be able to provide these books that are fairly heavy. We will send them to you. So why was this report necessary? There were anecdotal reports of a problem from developing country partners. Evidence from many high-income countries showed a high toll for preterm birth. The preterm birth was underreported and undervalued because people were not paying attention to problems of children. WHO for many, many years was concentrating on infectious diseases, and that was inevitable because it was such a serious problem, and still is, that killed many, many people. But when they decided to consider the underlying problem of non-communicable diseases, those diseases in their mind were diseases of old people. They did not remember the problem of children. And it's only recently that WHO has begun addressing, among the non-communicable diseases, problems of children. This is the first ever report with comparable country estimates. Preterm birth is a neglected problem, essential problem to solve if the Millennium goals will be achieved by the year 2015. Without that, that goal will be unachievable. So here are some selected countries that account for the largest numbers of preterm birth. India, China, Nigeria, Pakistan, Indonesia, United States, Bangladesh, Philippines, Democratic Republic of Congo, and Brazil are among the 10 countries with the highest rate. Qatar is somewhere in the middle with a rate of 10.6%. Here are some of the data on the rates. And 11 countries with preterm birth rates over 15%. We added the United States just to show you that it's 54th. But it's Malawi, Congo, Comoros, Zimbabwe, Equatorial Guinea, Mozambique, Gabon, Pakistan, Indonesia, Mauritania, and Botswana. 1.1 million of these preterm babies die, which is bad enough. But notice that 90% of extremely preterm babies in high-income countries survive, and yet fewer than 10% of identical babies in the developing countries survive. This discrepancy is shocking. Approximately 12.9 million babies are born every year, a global prevalence of 9.6. An estimated 28% of the 4 million annual neonatal deaths are due to preterm birth. In a global perspective, preterm birth is now a leading cause of neonatal and child death. It is the single most important cause of neonatal mortality and a second leading cause of under 5 deaths, 14% after pneumonia. In 2010, 7.6 million children died before their 5th birthday, which is down from 9.6 million in the year 2000. Evidence of increasing progress related to Millennium Development Goals. However, over 40% of these deaths now occur in the first month of life. This is the set of statistics that mandate that something be done about it. I will now make a few comments about what can be done right now and what we need to explore in order to solve the problem. I will show you two patterns, not because they are useful, but precisely because they are not. They have been published, and I have omitted the source because I didn't want to embarrass the authors. So this is one suggestion of how we try to find a way of the source of preterm birth, and here is the other. And if you were to follow either diagram in transposing it in your effort to build the causeway from here to Bahrain, you would wind up probably in the Emirates instead. So I'm not suggesting that this is an approach that would be of any manner that is useful. The March of Dimes and several other organizations, prompted by a report of the Institute of Medicine on preterm birth and from our Surgeon General's report, decided that basic research, the so-called discovery research, is absolutely essential. But we also ask, is there anything that can be done in the meantime? And the one thing that can be done is that there are efforts, particularly in countries of high resources, to reduce the number of induced labors. The iatrogenic process, the so-called elective induction or C-section for non-medical indications, is crucial. It is very important, and we have discovered that even 1 week earlier than the spontaneous birth that would occur is sufficient to create problems for the neonate. Multiple gestations are another reason. Of course, they're not always controlled because some of them are spontaneous, but in the reproductive assist situations, implantation of embryos in excessive numbers creates a very serious difficulty. Maternal disease, of course, preeclampsia and infections are things that must be treated, and obviously in a situation like that, one must induce labor. In the situation where one can abolish unnecessary induction, there is hope. You will notice here that in the last 2 years, when they have the data in the United States, the numbers that have been rising have begun going down to this point. The last data are for the year 2009. This gives us courage to believe that propaganda against elective inductions that are not necessary medically will reduce some number of preterm birth. But the ultimate solution must come from the biological understanding of that. And in order to create a philosophical atmosphere within which one can think in terms of independent, unorthodox ideas, we decided to suggest an old, or relatively old, philosophy initially enunciated by Piaget in Switzerland, having a transdisciplinary process. Transdisciplinary means that people of one discipline work within someone else's discipline. So a physicist and a geographer and a statistician and a communications expert would get together, discuss things, and any question asked by someone who has not been involved with the process begins to show that there are points of view from which we are constrained by our background. And thus, we are breaking those constraints. And we decided to create 5 such transdisciplinary centers in the United States that will progress along these patterns. It is not interdisciplinary, where people work independently but talk to each other. It is not translational research. It is a special point of view in which people sit down and talk and are not embarrassed to ask what might be naive questions if asked by one discipline, as long as it is asked independently within the other discipline. So we have a very interesting way of doing it. And our first demonstration program was established at Stanford University, and every Wednesday morning at 7:30, the entire group meets and they just talk, and then they record their observations. And they have begun going through this in an unorthodox way. Let me show you some of the things that are being done. Transdisciplinary approaches for this effort, and potential research targets. Theodosius Dobzhansky, who was a major biologist of the earlier part of the 20th century, said nothing in biology makes sense except in the light of evolution. And I'm going to show you some of the points that are being explored within this transdisciplinary process. This is a Neanderthal female pelvis, and you see the distinction between humans, in which the head of the fetus fits virtually with no extra space in the female pelvis, whereas in Neanderthals there was more room, and in the chimpanzee even more so. In other words, for human evolution, this is about the maximum that one can wait for the labor to initiate itself. And there must be an explanation within this circumstance that will lead us to the understanding of how that timing has been established. Because here you have the most evolved human head in contrast to the other non-human primates, and yet it cannot evolve any farther. So that balance might hold the secret to one of the stimuli for the labor. The other way of approaching this, and these are just the glimpses of things that are being considered, is clustering. What this rather complex model shows is communities in which the column going up indicates increase, column going down indicates decrease. If you begin to wonder why there is an increase in whatever you're observing versus a decrease, the number of possible reasons is enormous. It would be impossible really to sort it out. So a far better approach, if we're talking about rates of preterm birth, far better approach is, this is a model, is to look at one community, for example, in which you have a sudden change from going to a decrease to going to an increase, because the number of variables that might be responsible for this sudden change is much smaller. And you may be able to infer from that what may be one of the causes. We have such patterns for many, many communities in the United States, and here are ones from California in '71, but we have them for an entire country and for a number of years, over 20 decades. So this is one of the studies that are being done. I cannot go into details because of the limits on my time here, but this was one of the possibilities. Another one is study of microorganisms throughout our bodies. For a very long time, we have believed that if something that is cultured is negative, there is no microorganism. Now we know that there is myriad of microorganisms that are not culturable because we don't know how to support their nutritional requirements, and yet by metagenomic technique, one can discover that they're there. And looking at those as potential stimuli will be one of the ways in which our studies will now progress. We know, for example, quite clearly now that an infant born by a cesarean section has an entirely different microorganismal colonization than an infant born vaginally. Is there a reason there for the differences that may be responsible for the preterm labor? We don't know that yet. That will be studied. Another way in which we can approach it is looking at isolated communities. If the isolated community is at a very high altitude, it may have different patterns than communities that are at lower altitudes, and there may be clues to the search for that. One can identify genes that are implicated in changing that pattern. So what needs to be studied? There are social aspects, there is infection and inflammation, there's genetic predisposition, and there are animal models. The problem with animal models, and I'll mention that in another moment, is that none of them is going to be a perfect replica of what we're looking for. So one needs to select models, and I'll show you one very brief example in a few minutes. Social aspects, we must study of responses to stress caused by economic disparities, by single parenthood, by stigmatization, by poverty. One of the difficulties of prior studies has been that stress was interpreted by the investigators. We really need to interpret stress by the people who are experiencing it, because if you are affected by something, your reaction may be entirely different than that of the people who are studying you, and that will be now carried out. Infection and inflammation, the role of bacteria in reproductive tract, but also search for the unculturable microorganisms by metagenomics. There is also a problem with biofilms These are colonies of microorganisms that contain tremendous quantity of DNA and yet are totally isolated from the rest of the world. The study of inflammatory responses to those. We need to study by epidemiology populations, the genome-wide association studies, but those require very large numbers for them to be statistically significant. And I'll show you one aspect of genetics in a moment. Find pattern recognition discovery. Space-time patterns of preterm birth in terms of those clusters that I demonstrated for you before, seasonal effects, weather, geography, regional health risks, and other indicators using artificial intelligence and other non-traditional analytic techniques. In bioinformatics, we need to identify candidate genes, gene-environment interactions, novel maternal biomarkers for preterm birth by integrating genome-wide association studies, transcriptome, SNPs, gene regulatory networks. Placental implantation and function discovery. Explore placental genetics and epigenetics and their contribution to preterm birth. One of the things that is an enigma, is fascinating. In animals, just before labor starts, in a mouse or in the sheep, there's a tremendous drop of progesterone. In humans, absolutely not. Human fetus swims in progesterone, and yet, at this point, birth occurs, and entirely different from that. So it is not the lowering of progesterone, but the effective lowering of progesterone. Presumably, something happens that makes the end organ non-receptive to progesterone. It has never been answered, and therein must lie a very, very important answer. Now, I want to show you in 2 or 3 minutes that I have left a very important study that we carried out. There are true breeding mice at Jackson Laboratories in Maine, and these are 15 different true breeding cohorts. Every one of them has a different gestational period, which is absolutely fixed. It doesn't change no matter what. What we have done is taken one of these, let's call it a B and A, and fortunately for the experimental things, the B mice had severe combined immunodeficiency. In other words, they are completely immuno-unresponsive. And we transplanted into them A type of ovaries and fertilized these mice with males of the A type. So the pregnant B mouse in this experiment carried A fetuses and carried it to the gestational period of the B mouse. In other words, this shows that maternal genome controls that, not the fetal genome, not the paternal genome. And there's a reflection of it in human clinical studies because, as you know, that women whose ancestors had premature labor also have a higher rate of premature labor, whereas male lines do not in any way affect that. So I end by saying that, with Václav Havel, that hope is definitely not the same thing as optimism. It is not the conviction that something will turn out well, but the certainty that something makes sense regardless of how it turns out. And it is our intention to follow those studies. I apologize for the briefness of this, but all the time that I had left, I could spend an hour discussing several individual aspects of it, but Professor Dudenheimer will not allow me to do that. Thank you.
Thank you, Dr. Katz, for this global view of the main problem of obstetrics. and I think we will have a lot of questions to discuss later. As you know, Sidra has tried to bring together international scientists and scientists from Doha, and therefore I'm happy to welcome Dr. Hilal. He is the director of the Women's Hospital. I will be short to solve money, solve time, because all you know him, but he is a neonatologist and a famous one. Please, that's your floor.
Thank you. Bismillah ar-Rahman ar-Rahim. Good evening. God help me, I'm a tiny neonatologist squeezed between two giant obstetricians. Yeah. Right. I will try in the next allocated time of 15 minutes, I was told, to paint an overview of the prematurity trends in this country. I will touch on the outcomes and the volumes and how Qatar compares to international practice and to the past practice, compare the current to the past. My data is coming from the Pearl research study funded by Qatar National Research Fund and from the Vermont Expert Network and from research in our neonatal intensive care unit published in international journals in 2009 and 10. This is just an overview of the trends in delivery in Qatar. And it's actually, I don't know whether this slide showed it clearly, but it's nearly doubled up over the last decade. And most of the deliveries happen actually in women's hospital. And this is in 2011, and we grew by an additional 1,000 delivery in 2012. There's, as you can see, we were a decade ago maybe 50-50 Qatari and non-Qatari, and now that indicates that, this number indicates that there's a huge influx of expatriates into this country. Diabetes is approaching 25%. Nearly 18% is gestational diabetes. That's, diabetes in pregnancy. Diabetes mellitus is around 3%, and impaired glucose tolerance test is around 3%. Now, the other hospitals contribute only perhaps by 15% to the total deliveries in the country. And this is the newborn trends, which is a match to the deliveries. And as you can see, it's again nearly doubled. And again, most of the deliveries happened in women's hospital. We had over 18,000 deliveries last year. The contribution by other hospitals are much the same, maybe less by 300. Our C-section rate is rising slowly by 1 to 2% every year. And in 2012, it touched 25%. Nearly 10% of the newborns are admitted to our neonatal intensive care unit. 50% of this figure is premature babies, and about 7% of that 50 is extremely low birth weight and threshold of viability. And this is the preterm multiple birth rate. And in 2012, we had the highest of all years, 379 multiples. We had the highest of twins, 348. And we had the highest of triplets. However, in quadruplets, the highest was in 2007. And in 5 babies, quintuplets, we had 2 sets in 2006, and 1 in 9, and 1 in 10. And we had actually an 80% survival rate in these sets of quintuplets. Now this slide to show you the incidence of low birth weight, and most of them, this is the country, this is in women's hospital, and most of the tiny ones again get transferred eventually to the women's. And this is the split up of low birth weight, and you can see here 1.2 is under 1,500 grams, and 1.67 is 1,500 to 2,000 grams. So it's obvious that over 2,500 or 2.5 kg is 91.2. So the low birth weight rate is 8.8%. It has been more or less hovering around this figure over the years. The preterm birth is again, I will show you the split up. 1,530 happens in women's hospital. And again, most of these tiny ones, they get transferred eventually to women's. And this is the split up for the different gestational ages. And as you can see, under 29-week gestation is 1.79%, and 6.7 is the higher category of birth rate. So the preterm or the lower gestational age rate is 8.5%, and has been actually over the last decade more or less roaming around that figure. Although it's 8.5% of all births, but it makes 72.5% when it comes to death. And most of these deaths, nearly half of the 72%, happens in under 27 weekers. Obviously, they are very fragile and vulnerable population. 1/4 of deaths in prematures happen because of lethal congenital abnormalities. And the 3/4 of the death is because of the extreme prematurity. Now, this is the figures from our unit, and this is from 2011. We had a 39% survival in the 500 to 750 grams. Between 750 to 1,000 grams, that's 80%. And to sum up, the under 1 kg, 1 kilogram, is 68%. The between 1 kg and 1.5 kg is 93%. And between under 2 kilograms, between 1.5 to 2 kilograms to 2.5 kilograms is 98%. Now, this is the neonatal mortality rate in 2012, and these are the crude numbers, uncorrected, and these are corrected numbers, actually, because we've taken out the lethal congenital abnormalities and the threshold of viability. Babies who are born, say, 22 weeks, 23 weeks, 24 weeks in a very bad shape, they are actually born with signs of life, with no really, they survive for an hour or 30 minutes or 3 hours, but they have no potential actually to survive. So, but they confound our ultimate figures and mortalities. So that's how we look uncorrected, and this is when we take the lethal congenital anomalies, because we are actually strict in this country when it comes to termination of pregnancies. And this is how we compare to other well-to-do countries. We're doing very well in terms of the early neonatal mortality rates. And this is how Qatar compares to the, again, surrounding countries and one of the prosperous countries, actually. We are here if our neonatal mortality rate is uncorrected, and if we take the lethal anomalies and the extreme preterms, and then, 24 weekers, and then we are really compare very well with the international figures. This is some figures of morbidity, and this is a comparison between 2002 and 2011. And I've just picked up on a few, like the patent ductus arteriosus. We have a significant p-value. The necrotizing enterocolitis is much lower. The brain hemorrhages are much lower. And the retinopathy of prematurity is much, much improved. And this is how we compare to the international network. This is called the Vermont Expert Network, which we subscribe to. And we notably are doing really very well in chronic lung disease with lower incidence, and in brain hemorrhages and ROP, retinopathy of prematurity. And these are figures from our neurodevelopmental clinic. We had, in half of 2008, 2009 and 2010, we graduated really 883 babies, but only 162 qualified for this examination at 2 years, because the others were normal, very normal. So only 162 qualified. And if you take the incidence of cerebral palsy, then you will find, if you take the incidence from the total, then this 4%, and developmental delay about 3%, and speech delay is 0.8%, which is extremely good, really, short-term outcome. So to summarize, between 75 over the last 36 years, Qatar increased tenfolds in terms of population, 7.2-folds in terms of deliveries. However, the neonatal mortality rate dropped by 87%, early neonatal mortality rate by 91%, and late neonatal mortality rate by 58%. And so you see the graph is maintained despite the doubling the birth rate. And the impact is really mainly fell on the under 32-week gestation. And this is the trend in a graph. And you can see we had a dramatic drop here and then another drop over the last decade. And this is because of many reasons. Improved perinatal care, obstetric care, delivery care, and perhaps neonatal resuscitation. We had an accredited, internationally accredited neonatal resource program. So you can see now the drop in hypoxic ischemic encephalopathy. And we introduce the total body cooling and cerebral monitoring function to the unit. This is a great achievement by Qatar, actually, the universal newborn screening to all population, free of charge. And it's for the early identification of endocrine and metabolic disorders and other disorders, and the early intervention and treatment has salvaged a lot of lives. And this is part of the screening program, the vision screening. It starts at the neonatal intensive care unit and extends to the school children, nurseries, school children at all ages. And, but it starts here, and you can see in 2011, we screened our 228 babies qualified for the screen. That's under 1,500 grams and 31-week gestation. And we got 6 babies with some retinopathy that was treated, but 0 incidence of adverse outcomes or retinal detachment. I'm not going to talk about the latest advances in treatment and management, and I'm not going to touch on oscillation or nitric oxide and all these fancy modalities of ventilation. But I think it's the most important development in neonatology care is that we calm down, actually. We are less aggressive in everything. We are more tender and loving and patient with these tiny ones because they are very fragile, they are very delicate. So we introduce into the service the latest practice, like the golden hour, the first hour of life. We call it the precious golden hour. So to ensure that the baby has a calm transition into life. So we stabilize very gently, and we blend oxygen with air, so we don't give 100% oxygen because that's the latest practice. It's very damaging to all body tissues. Gentle, non-invasive ventilation like CPAP. We started that in labor room. We give surfactant in labor room. A lot of monitoring is happening in labor room. We established a tiny baby unit where under 28 weeks gestation babies are wheeled into and for better focus and for expert dealings. And the rest of it, we take so many measures to ensure the baby safety. I just want to show you this, the premise of history, the Einstein and Newton and Picasso. I disagree with this one, Napoleon, but I think he's a war hero, so I will take him out. Because we do get from our babies genius ones, actually. And so premature babies could generate lifeline of good quality survivors. And this is my last slide. This is a photo taken in our NICU, won the gold medal prize in an Austria exhibition in 2010. So it's just out of 84,000 photos from all over the world. This won the golden medal. Probably it will indicate how much passion out there in the world for premature babies, how much passion, empathy, and sympathy. And thank you very much.
Thank you, Dr. Hilal, for these results, and congratulations for you and the team of your department for these results and the dramatic changes during the last years. I must ask you to stay a little bit, I have to tell you some aspects of preterm labor diagnosis and treatment from the point of view of the obstetrician. Dr. Katz mentioned that there are different reasons for preterm labor. There are medical indications for preeclampsia, eclampsia, or severe diabetes, where it is an indication for finishing pregnancy, or it is a preterm rupture of membranes. It's a very different aspect of management here. We speak today from the spontaneous preterm labor with intact membranes, and all what I mention now in the coming minutes is to this group, spontaneous preterm labor with intact membranes, and I'm focused on the pregnancies lower than 32 weeks. That are the real problems, and not the for the discussion of preterm labor and the long-term following. The late preterm is a problem we have to take out of this, and we have to focus another symposium to reduce this preterm labor and the danger of late preterm labor. What is preterm labor? There is a lot of different definitions, but international accepted is this definition, and I propose and I ask you to use this one. It's between 20 and 34 weeks, spontaneous contractions more than 3 per 30 minutes. Not every contraction of a pregnant woman is preterm labor. It has to be 3 and more per 30 minutes. And not only contractions, and shortening of the cervix. And this shortening of the cervix is not a result of digital examination and vaginal examination. It has to be the result of transvaginal sonography. And the normal cervix is 40 millimeters, and it is pathological short if the cervix is in singleton pregnancy lower than 25, and in multiple pregnancy lower than 30. This is more or less the result of international eminence discussion and eminence-based knowledge. Instead of the shortening of the cervix, and or can be a dilatation of the cervix more than 2 millimeters, and I wish to discuss some minutes later the fetal fibronectin in the vaginal smear. This is a picture from the transvaginal sonography. You see here the internal os and the external os. That is the distance of the cervical canal and is 2.3 millimeters, a little bit short. This is a shortening cervix. And it is very important to finish this not reproducible digital examination of the cervix as a marker of the preterm labor. We have to do it with ultrasound, transvaginal ultrasonography. We can do it a little bit more sophisticated with three-dimensional ultrasonography, then we can see the dilatation of the cervix, but it's not necessary. The transvaginal normal ultrasonography is enough for this diagnosis. There is a good correlation between the shortenings in the cervix and the time up to the preterm delivery. Shorter the cervix, shorter the time for the preterm delivery. And that's the background of this transvaginal sonography. And this prospective value of the shortening of the cervix can be increased with the measurement of the fetal fibronectin. It's a bedside method, very easy, and the prospective value of the diagnosis preterm labor is increasing. the fetal fibronectin is a glue between, or fibronectin is a glue between cells, and if the cells are moving against, for instance, in the fetal membranes, or then this fibronectin produced from fetal cells is free and is measurable in the vaginal smear, as it is shown here. Then you can do it as a bedside method, and you can say there is fetal fibronectin or not. Positive or negative result is enough for this. And if the result is positive, then the risk of a preterm labor is higher than with the ultrasonography alone. Therefore, the combination of vaginal ultrasonography and the fetal fibronectin is in the year 2012 or 13 the real method for predict a preterm labor. There is one prevention method, well accepted international and well documented in prospective studies. That is the progesterone treatment or prevention vaginally. If you have a pregnant woman with a short cervix, lower than 25 weeks, cervix lower than 25 millimeters, and important, singleton pregnancy, and you treat this women with 200 milligrams progesterone as suppository vaginally, then you can reduce significantly the rate of preterm birth. There are several studies. One of the first was last year from Roberto Romero in the American Journal, but in the meantime there are several studies, and this result is very clear and acceptable. It is important to stress that the same results are not reproducible in twins or multiples. There are several prospective studies. They show that this decrease in preterm labor is not, will not happen if the same treatment is done in multiple pregnancy. This can be done as prevention in pregnant women with preterm labor in history in normal cervix, and it has to be started in the 14th week in these cases, and the studies are clear, have clear results that in this high-risk pregnant women, the rate of preterm labor and preterm birth is decreasing with this treatment. That is a real secondary prevention. If we wish to prolong the pregnancy with any treatment, tocolytics, and which we wish now to discuss, we have to look for contraindications for preterm treatment with tocolytics. It's a clear contraindication is intrauterine infection, and in some cases, and in pathological fetal heart rate patterns or pathological flow patterns. There is a contraindication. It is better to finish the pregnancy vaginally or abdominally than to prolong pregnancy. And the same can be, must not be, is case-to-case decisions in cases with intrauterine growth retardation. These are the contraindication for prolong the pregnancy. What is the idea to prolong pregnancy? Not to prolong pregnancy over weeks and months, and therefore it is only the idea of this treatment to prolong pregnancy 48 hours, enough time for the antenatal corticosteroid therapy. There is one important change in perinatal medicine during the last 40 years. That is the introduction from the antepartum steroid therapy from ligands in 1972. With this result, we can reduce the morbidity and the mortality of preterm babies, and therefore it is important that every woman lower than 34 weeks get antenatal corticosteroids, And to be able to treat 48 hours the patient, it is important to prolong the pregnancy 48 hours. Once more, it is not the reduction of preterm rate, the idea of tocolytic treatment. The idea of tocolytic treatment is to prolong pregnancy for the antenatal corticoids therapy and to transfer the patient, if she is not in a perinatal center, to transfer the patient to a place where the neonatal treatment is optimal, or as I call it, perinatal center. With this idea of tocolytic treatment, there is a big number of different substances published as tocolytic agents. For instance, the most used in the world or last 10 years, 20 years are the beta-mimetics. The beta-mimetics, the Royal College of Obstetricians and Gynecologists made the statement, the time is over for beta-mimetics. I agree totally. The side effects of beta-mimetics are very severe. 1 in 400 cases of mothers treated with beta-mimetics get a lung edema. There are maternal deaths are published. I think beta-mimetics are not, have no place in the treatment of preterm labor. A very well used substance is magnesium. It is one of the 2 substances accepted from the Food and Drug Administration in the States for preterm labor. It's bad, but the prospective studies are very clear. The magnesium has no tocolytic effects, and therefore magnesium isn't a tocolytic drug. It is the place of magnesium in obstetrics is for treatment of hypertension, preeclampsia and eclampsia, but not of preterm labor. The perinatal mortality in the group of magnesium-treated women is higher than in the group without magnesium treatment. Therefore, magnesium treatment hasn't a place in the preterm labor treatment. Indomethacin is a relatively good tocolytic drug with a lot of side effects. For instance, the closing of the ductus botalli. Therefore, I think it's not a real indication in obstetrics. Nitric oxide donors it's possible to reduce the contraction with this substance, but the side effects of headaches, of severe headaches, normally finish this treatment. Therefore, it's not very well used. Used are the calcium antagonists, and there are a lot of prospective studies that they have a tocolytic effect from 7 to 14 days, and therefore with these substances you can prolong the pregnancy for 48 hours. But the latest, and here you have the dosage of nifedipine, that's one of these canal blockers. The side effect of this is the arterial hypotension. Therefore, you have to be careful with this higher dosage in the beginning. Therefore, you can use a lower dosage. You have to look for the effect of the contractions. Atosiban is the latest development of the tocolytic drugs. That is oxytocin receptor antagonists, and from my point of view, it's the first choice of treatment of preterm labor. Prospective studies are very clear. It's evidence-based that these substances are able to prolong pregnancy 7 days, and therefore the side effects are very low, and therefore I think that is the substance of the first choice. Summarize it. A lot of studies are done about the treatment of preterm labor with antibiotics. Very clear answer, there is no place for antibiotic therapy in the preterm labor. It is different from cases with rupture of membranes, different management, but with intact membranes, there is no place for antibiotics therapy of preterm labor. And then worldwide, since Shirotka published his idea of cerclage, the cervix, in the 60s last century, there are a lot of different methods and a lot of studies. You can read whole libraries with such studies, but under the line, there's only the indication for cerclage in emergency cases if you have a dilatation from 2 to 3 centimeters to 4 centimeters in the 28th week. That is an indication of a cerclage with. There are some case studies where the result of the early diagnosis, early treatment after diagnosis are positive. And there are studies during the last 2-3 years with shortening cervix, ultrasonographically measured, risk history of the mother, and without any contraindication like infection or so. In these cases, you can think about cerclage. Studies with 40, 50 cases are done in some centers. One special method of cerclage is the total cervix occlusion. There is no evidence base that this method is with a positive result, but it is very difficult to do a positive prospective study in this. This is the original picture from Shirotka with his cerclage. More familiar maybe you are with the method of MacDonald, but more or less all the same, a little bit different from the method. This is the total occlusion. The idea of total occlusion of the cervix is that there is a barrier between the vagina and the intrauterine space. Any bacteria cannot pass the cervix, and therefore you delete the upper tissue of the cervix like a very small conization, and then you make some sutures, and after 2 weeks you see that the external os is closed and it will be reopened from the normal spontaneous contractions at term. That is not an operational problem. I think in the end of all this operational or drug discussion, the most important method for preterm labor is the primary prevention, to educate young non-pregnant women that smoking is bad for herself and for the pregnancy and for the length of pregnancy, that drinking alcohol is bad for herself, for the pregnancy and for the fetus and for the length of the pregnancy. That are primary health aspects of this preterm labor. And if somebody has preterm labor, you have to prolong pregnancy for the antenatal corticosteroids. That is a real progress at this point. All the other things are ideas with more or less value. Thank you. The three speakers wish to answer your questions. Now you can answer, or you can ask questions to high sophisticated two speakers about global or local questions about preterm labor. Please.
Yes, my question to Dr. Hilal regarding the neurodevelopmental outcome in your slide you showed, because you assess them at 2 years of age. Do you think it's too early for this to be assessed, especially diagnosing a cerebral palsy?
No, they get followed up all through. But these are the results at 2 years. But that's not the end of the follow-up. This will continue. These are what I presented are the results from half of 2008 and 2009 and 10. We're still looking and validating the results of 2011 and 12. But these babies will continue to enroll in this follow-up.
I would like to ask about the terminology of toxemia of pregnancy. Does this still exist? And if it is recurrent in pregnancies, as I was one of the victims, and in 3 pregnancies, I went through this, and the baby could not go beyond 4 months, and it was only 1 baby that we could survive, and the other 2 could not. So what is toxemia and how we could prevent it?
If I understand the question, connection between preterm labor and preeclampsia, that's right?
This
But
they had
I-
to induce it and
Sorry,
take out the baby.
I change it a little bit. Because today we are speaking of preterm labor. And you are right in the point that preterm labor, because of medical indication for the mother, is to reduce or can be reduced with the treatment of the mother for instance, preeclampsia. Therefore, it is important to have early signs of preeclampsia, not in the 28th or 29th week if the preeclampsia is starting. You have to look for the flow, for instance, the Doppler flow very early, and then you have to start with the treatment of the preeclampsia, hoping that you can continue the pregnancy up to the term. But there will be some cases where the preeclampsia is starting very early, and these are the dangerous cases for preterm labor, for instance.
But this toxemia that I'm mentioning is before that, within the 5th or 6th month, and there is no preeclampsia. But the baby doesn't grow, and there is risk for the baby to die inside, and a risk for the mother also. And they have to remove the baby, at 5 months or even earlier, if you want to even survive the mother.
Yeah.
I just wanted to add that what we have been discussing is spontaneous preterm labor. There are obviously indications where one must make the judgment that the danger of continuing pregnancy is worse than the danger of early interruption. Those are the unfortunate things. Preeclampsia is a very complicated problem, and as far as I know, there is really no solution to it at the moment. The only advantage that has been adduced to it has been the early prediction that preeclampsia will occur. But other than tearing your hair out, I don't know what you can do to prevent it.
I think the early prevention with Doppler flow, for instance, is one of the methods which has been done in all pregnant women.
Right.
That's in the 21st week, for instance.
I think the most important sentence you mentioned in your lecture, that if you prolong the labor for the effect of the antenatal steroid is the best. I think after the revolution of introduction, the surfactant and the use of total parenteral nutrition, for the last 10 years, the percentage of preterm labor almost static. And my question is there any target to decrease the percentage of preterm labor? Or is it just to stop with your last sentence? Is there any room other than the biological study, research, and these things? But for the last 10 years, there is no improvement in the percentage of preterm labor.
You are right, there is no improvement. In contrast, in some countries, the number of preterm birth and preterm labor are increasing. We can discuss a lot about the reasons. One reason is, or two reasons, maybe the following. One is the increasing age of the first pregnancy, and with increasing age you have a lot of problems. You can have a lot of problems. And the second increase, and that is not only a theory, I can show you numbers from Germany and from Berlin, that the production of multiples increase the rate of preterm babies. For instance, the perinatal mortality in Germany decreased over several years, and this decrease is, there is a rebound effect now because of these two population changing things. Therefore, we must try that the first child in the industrialized world, it is now with 30 years, 29 years. We have to reduce it. It's a very important point. Public health problem.
Yes, it's very serious, and you know, there are so many stimuli toward this. The independence of women who are in the workforce, very, very complicated problem. You know, one of the things that happen in the world is that society evolves in one direction. The consequences of that evolution are very complicated and difficult to predict, and we have to adjust to that. There are, fortunately, many ways in which one can attempt to respond to that, and if we ever find a means of preventing preterm labor that is spontaneous, some of the things that Professor Budenheimer just pointed out may be overcome.
There is a great room really for improvement. If we deliver better care in primary health care, if we develop community care better, primary health care, antenatal care, and the last thing is the perinatal when they come to hospital. I think there is a great potential for improvement. And as you know, the development in this country is marching with the Supreme Council health programs being introduced. I think in the next few years we will probably see all these programs maturing and perhaps with a great impact on the rate of prematurity.
In general, I think this is a good principle, that if you follow the best available practices, things will get better. Unfortunately, in terms of spontaneous preterm birth, there is no evidence that no matter what you do in terms of following good prenatal care, that will change it. There is a force that we have not yet recognized that creates spontaneous, unnecessary, early.
But I think there are data that good antenatal care increase the follow-up studies.
Yes,
survival.
absolutely.
Yeah.
Survival, yes.
And
Incidence, no.
therefore, I think it's important to diagnose preterm labor early,
Sure.
and therefore you need antenatal care with, for instance, transvaginal ultrasound or something.
No, I would like to emphasize that achievements in survival of the prematures have been remarkable. People like you and all the neonatologists have succeeded in maintaining these children who survive not only alive, but also without major defects, sometimes without any defects, thanks to the very, very hard work of people like you.
It's not me, it's the dedicated teams in the neonatal intensive care unit, the obstetricians,
Well, but it's the
our
intellectual...
friends, the obstetricians, who are delivering great outcomes, and the pediatric subspecialties, all pediatric subspecialties. They've been a great help to the neonatal intensive care service.
The lady behind, please.
question is regarding the use of tocolytic in pregnancy. As it mentioned in the guideline and in your lecture, that tocolytics should be only used in the first 48 hours for prolongation and for dexamethasone or betamethasone use. However, in extreme prematurity, when we want to prolong more than this 48 hours a week, can we use the tocolytics, for example, like calcium channel blockers or magnesium, to gain more time, or is still controversial or a complete contraindication?
You mentioned magnesium. I don't speak for magnesium. Magnesium has no tocolytic effect. If you take nifedipine or atosiban, you can do it. It is prospective studies. It is done, or it is shown that you can prolong pregnancy up to 7 days. But I would propose to finish after 48 hours, and if the contraction will start again, to start once more with tocolytic drug like atosiban or nifedipine. I would really finish with 48 hours, and this is in line with the Royal College of Obstetrics and Gynecology guidelines and the American guidelines, the guidelines of the American College of Obstetrics and Gynecologists. Dr. Manzoor?
I would like to thank everybody. I
Can hear you.
Yeah, I really enjoyed your talks, the three speakers. I'm a pediatric surgeon. I work very closely with our neonatologist. I just want to get your opinion. Are we losing the battle of prevention, and we should concentrate on our winning battle, which is keeping these babies alive by improving the intensive care management of these patients? Or we still have to go after prevention and understanding the root cause of preterm labor?
What is more important, prevention, the battle with prevention, or the battle with
Well,
survival?
you know, medicine is anti-evolutionary. It tries to save everyone who is about to be alive. But the ideal thing is obviously staving the problem rather than solving the problem. If the problem doesn't occur, you have gained a lot. Yet we as physicians have been taught to treat, and that is our profession. So there's always this dichotomy. Very difficult to convince yourself that something that doesn't happen is a great achievement. If you get a patient, and I believe you're a surgeon, that if a patient comes in and is desperately ill, and you make an incision and within 25 minutes resolve the problem, and ultimately the patient walks out healthy, it's a great satisfaction. But if you could prevent this from happening, and the patient would never have to see you, this would have been a great achievement that is not recognized. So we are dealing with this philosophical dichotomy. And I can tell you from a personal experience as a physician that nothing gave me more satisfaction than treating a sick patient who gets better. But it is a mature recollection of the fact that it would be better to have this disease not occur. Smoking, which was stopped in many, many countries, has saved more lives than a surgical removal of cancerous lungs.
We don't know really what the future holds here. What was impossible and unthinkable 20 years ago is quite possible now. So we need to continue driving this optimism and hope. And what seems to us at the moment, for example, a threshold of 23 weeker is, or 22 weeker is really, people tried all over the world and failed. But that takes us to the late 80s when people tried with different models of surfactant and, you know, lung juices, and they didn't win. But eventually in the 90s, you know, innovative discoveries and research had really turned the whole corner. So we don't know. At the moment, I think we are struggling in this extremely low birth weight because of, you're ventilating a lung that is not formed. There are no alveoli at all. So we're paddling, we're struggling. But we don't know what the future holds.
Yes. Dr. Rashid from the Fetal Maternal Center. I wanted to ask a question. You said about the cervical cerclage, and you spoke on total occlusion. I have not done it, and I have not heard about it. I did hear about the abdominal approach to cervical cerclage. So I wanted to know the difference and the indication that you apply to when you do a total occlusion. And in terms of then the after effect, how do you conduct the delivery? I mean, they spontaneously dilate or you go for a C-section?
Yeah, I understand your question. It's published, I think, in the 70s last century. And it is the typical indication is if you have a woman with 2 miscarriage or 2 early pregnancy as a result of ascending infection. You can prevent the ascending infection with closing the cervix. And there's the problem if the mother is starting contraction, normally it will open itself, or you take a Caesar and make you need a little bit epidural anesthesia. No, that isn't a problem. For a real obstetrician, isn't a problem.
And what about the abdominal approach? That was initially started, I think, in Egypt, and then went to the UK. It was started in King's College, and there was a lot of success on that.
Yeah.
They go through abdominally and dissect the bladder and then put the cerclage.
Yeah, I think there are some indications, for instance, after cancer operation of the mother and so on, there are some indications for abdominal cerclage, but they are rare. And I don't know any prospective study. It's maybe a little bit difficult to do it. But I think in some special cases there is a place for abdominal cerclage.
Thank you.
Welcome. Last question.
Thank you very much, Dr. Ahmed Talisi from Al Wakra Hospital. My question is regarding the use of progesterone as preventative measure for preterm labor. Dr. Katz mentioned in his lecture that the baby is swimming in progesterone. And despite the fact that the baby is swimming in progesterone, the preterm labor still occurs. And in your lecture, you mentioned that it's very effective in preventing preterm labor. So I'm not very clear whether we have to use it, or is there any point if there is plenty of progesterone and it's not effective? Thank you.
The first point is that I propose the progesterone as local treatment. It is not given intravenous or whatever, intramuscularly or so. It is a local effect on the cervix. And that is the result of animal studies with this progesterone treatment. It's a local effect on the receptors in the cervix. And that may be the explanation for this difference in...
Yes, it has to be 17p. Yes, that works. So that the end organs response is an issue, probably, but it has not been resolved. One of the big mysteries.
But it's maybe not very, we cannot explain it correctly,
That's
but
right.
the prospective studies are very clear.
Yeah, no, there's no question that it works.
Yeah.
And we have many situations where things work, but we don't know why. I would rather have things that work without knowing why than if I know why and they don't work. So it doesn't matter.
Okay, thank you. Thank you to you all listening to the speaker and to the discussion, and I thank you for your long and not so long trip to come to this hotel.